Welcome everybody to our second session of Perinatal Mental Health 101. For those of you that joined us last week, you know who our fearless speaker is today, but I'll just reintroduce her here in a second. I do want to start out with saying these two like 101, 102 level sessions are really something that we wanted to provide broadly to folks to be able to prepare anybody for the upcoming perinatal mental health conference. We'll be doing a combination in-person and virtual learning experience, in person in Helena, October 15th and 16th, and then virtually October 22nd and 24th as well. Somebody can pop the link to that conference page in the chat here. Registration is now open. There's also a scholarship link if you need some help getting to those conferences, and a lot of different ways to participate. One of the things that I do want to highlight is that we have a call for posters out. This year, we would love to have local work that's happening connect with one another through a poster session. So if you or your community or some organization you're working with would like to be able to share broadly with others from across the state what you're doing to improve perinatal and infant and early childhood mental health conditions in your community, we'd love to hear about that. So check out that conference page for the Lifting Up Local session. And yeah, come share with us and learn from one another. It's the best part about doing this work. I can honestly say that. So without further ado, I will introduce Dr. Samantha Greenberg. Dr. Greenberg comes from the Flathead, or is hailing from the Flathead currently. She didn't come from there originally, but she is a professor in the family medicine residency program of Western Montana and is an incredible leader in perinatal mental health. And I'm so excited to be able to welcome her into this space. Dr. Greenberg, I will turn it over to you.
Hello, thanks for having me again, and thanks for those kind words. Like Stephanie said, my name is Samantha Greenberg. I use she, her pronouns. I'm the site director in Kalispell for the Family Medicine Residency of Western Montana. And I'm a family physician who does obstetrical care as part of my practice, and have, I guess, a large part of my practice working for a federally qualified health center has always been caring for people who are marginalized or underserved. And I had explained last week sort of my journey to finding work in peripartum mental health. But unlike peripartum mental health, where I feel like I wouldn't say that I'm a content expert per se, but like I have had a lot more sort of underpinnings in that. I'm newer to the world of opiate use disorder. I'm by no means, I would say, an expert in treating patients with opiate use disorder, but my goal is to share some experiences that I have from working with patients experiencing substance use disorder and sort of approaching it from a social justice lens and thinking about how we can support patients in this very vulnerable time. Our objectives for today are to provide person-centered language to use when caring for persons with substance use disorder. We're going to describe the treatment options for opiate use disorder during the peripartum period. We're going to understand the presentation of neonatal opiate withdrawal and how to support families to minimize withdrawal symptoms. We'll explore the role of all of us working in sort of the healthcare milieu in screening for substance use disorder and reporting, and then discuss how we can create environments. And this is really what I want to emphasize our talk on, discuss how we can create environments that are safe and welcoming for people experiencing substance use disorder in the peripartum period. I have nothing to disclose other than I will endeavor to use sort of gender inclusive language, but knowing that a lot of the research and data and statistics that we have on people in the peripartum period do refer to birthing people as women or female identifying. So there will be a little bit of mix in that. So we're going to start with just some definitions. So substance use disorder is a chronic and treatable disease, often with expected lapses. Um, I want to highlight that that's the first line. So we treat and think about substance use disorder sort of colloquially in our um, environment, I think is really different than that, right? But at its heart, it is a chronic disease with expected lapses, like diabetes is, like heart disease is. And if we can sort of reframe it that way, I think hopefully we can get a little bit closer to being able to provide patients the care that they really need in a supportive way. Substance use disorder can refer to many things, both legal and illicit substances. You can have a substance use disorder to caffeine or nicotine, which is illegal, cannabis, which is legal in Montana, alcohol, or to opiates or opioids. They're just different terms for sort of the same thing, or stimulant medications like methamphetamine or other stimulants. Opiate use disorder specifically, which we're going to mostly talk about today, but mostly talking about opiate use disorder because there's more treatment options for it. But a lot of what we're going to talk about today can be applied to many other types of substance use disorder. Opiate use disorder, or OUD, is a problematic pattern of opiate use leading to clinically significant impairment or distress. And again, if you were here last week, we talked about what's the difference between PMADs and peripartum adjustment, or sort of what we'd typically expect. It's about the amount of impairment or distress. Those were two of the things we considered that it's causing to a person's life. Typically, patients who have an opiate use disorder will experience a strong desire for opioids, and an inability to control or reduce their use or continued use despite it interfering with their lives, and possibly a need to use larger amounts over time due to tolerance. And patients will oftentimes, or people experiencing opiate use disorder, will oftentimes spend a great deal of time obtaining and using their substance. It can be treated with a combination of medication, behavioral therapy, and support, just like many other medical conditions. And then I want to define withdrawal because we will talk about that a little bit. Withdrawal means the physical or psychological symptoms that stem from dependence on a substance and are usually related to tapering that substance or stopping it. And symptoms can include negative mood, nausea, vomiting, muscle aches, diarrhea, fever, insomnia. And some people may experience other symptoms besides that as well. But these are some of the definitions to keep in mind as we're going through the rest of our talk today. So let's talk a little bit about the epidemiology of substance use disorders in pregnancy. Even though we're talking about opiates today, in reality, the most common substances being used are alcohol and tobacco, both legal substances. And they actually probably have wider spread population effects than anything else. Alcohol can cause a wide variety of presentations that we sort of lump under this concept of fetal alcohol spectrum disorders, which replaces the old terminology of fetal alcohol syndrome. And tobacco can cause growth restriction and preterm birth. Marijuana is our most common illicit, depending on where you live, if it's illicit or not. But in Montana and in the rest of the United States, marijuana is probably the most common controlled substance. And if we look at some of the data, it's a little bit old, but still applies to now. In 2015, more than 27 million people in the US reported using an illicit drug or misuse of prescription drug in the last 30 days. And specifically, if we look at Montana, and the data is from Medicaid, just because that's where we could pull the data from, not specifically calling out patients that are on Medicaid. But 1 in 8 births that are insured by Medicaid in Montana experience some perinatal substance exposure. Oh, that firmware is showing up. Okay, we're going to cancel it.
We got one little pop. There you go. You're good now.
We're good. Hopefully it's not going to keep coming back. Okay. Specifically thinking about the opioid epidemic in pregnancy, opiate use disorder is undergoing the most rapid increase nationwide and in pregnancy, with the rate of opiate use disorder in pregnancy increasing 131% from 2010 to 2017. And that's continuing in our current data as well. In 2019, self-reported data showed that 7% of women reported use of a prescription opioid medication, and that's just prescription. We're not talking about illicit use. And 1 in 5 reported misuse of that prescription opioid medication. In addition to the rise in opiate use, both in pregnancy and outside of pregnancy. We're also seeing a newer continued rise in methamphetamine, and oftentimes we're seeing them used in combination with each other. And methamphetamine has its own distinct impacts on pregnancy. Most commonly, you're going to see some acute impacts later in pregnancy. But we're really not going to focus on that. But keep in mind, we're seeing a lot of those used in combination. In the US now, most illicit opiates are fentanyl. Or at least have some trace of fentanyl. And I think most people who are using, and especially in Montana and in the Flathead foreshore, I don't know about other places in Montana, but I would expect it's the same. Almost all opiates that people are taking, that they're obtaining illicitly, are fentanyl. And patients know that, and just assume that they're using fentanyl or are looking for fentanyl in specific. And again, we said opiate use disorder, we're also seeing a rise in co-occurring methamphetamine use disorder, but even outside of methamphetamine, we're oftentimes seeing people not using just one substance. People will oftentimes combine opiate use with others, tobacco being most common. About 92% of people who are using opioids are also using tobacco. So why do we care about opiate use in pregnancy? There's actually no clear data that opioids alone are associated with birth defects. That being said, the data we do have is hard to interpret because, like we said, opiate use is often associated with other substances and other high-risk behavior that may be putting someone or their pregnancy at risk. And so it is hard to really tease those pieces out, but there's no evidence that opioids in and of itself cause a birth defect in a pregnancy. But we know that opioid use is associated with inconsistent prenatal care, poor nutrition, growth restriction of a fetus, placental abruption, which probably is not due to opiate use disorder in and of itself. It's probably associated with co-occurring substances, namely methamphetamine or cocaine, is the most likely thing to cause placental abruption, which is basically a separation of the placenta from the wall of the uterus and bleeding, which results in a preterm delivery. Preterm labor and preterm delivery are associated with opioid use. Again, we don't necessarily think it's related to the opioids, but it's related to probably some of the other things that are going on in sort of the life of someone who is pregnant at that same time, including inconsistent prenatal care or nutrition, maybe some medically indicated preterm labor because of what's been going on. In labor, babies exposed to opioids during pregnancy are more likely to pass meconium prior to birth. So that's passing stool prior to delivery, which can cause respiratory distress at birth. There's an association with increased risk of fetal death or stillbirth. And then risks that are associated with using opioids in general. There's increased risk that we're engaging in high-risk behaviors such as prostitution or trading sex for drugs, and the risks specifically related to IV drug use, also including STIs, HIV, and a higher risk of interpersonal violence. And then there's a risk of maternal overdose and death, which we definitely want to avoid. So even though it's not necessarily causing a birth defect, there's lots of reasons for us to care about opioid use disorder in pregnancy. The opioid use in pregnancy is associated with a lot of barriers to care, which really are what's probably contributing to a lot of these negative outcomes that we're seeing in birth. So pregnant individuals with substance use face legal consequences, and that may deter them from accessing care, right? So they may enter prenatal care late or may not access prenatal care at all because they're afraid that if they present, something bad will happen to them. And so they would prefer not to present in fear that if they don't, then these negative consequences won't happen. And we know that that's not true, right? But that's something that people are really concerned about. Yes, they will face negative consequences. That's not untrue. But by not presenting at all, that's not like making it better, right? Substance use in pregnancy can be associated with shame and stigma, which may lead patients to avoid accessing care. I don't think anyone who's using a substance in pregnancy is like, I feel like this is a great idea, and I'm really like pleased that I'm doing this, right? People know that this is not something that they want to be doing or they feel really stigmatized by, and they're afraid to access care because want people to judge them or treat them badly. We know that substance use disorder and peripartum mood and anxiety disorders, which we talked about last week, are often co-occurring. And so the barriers related to PMADs are compounding with those of substance use, and so making it even harder for people to access care. And because patients may avoid care, we're not able to get them linked to the resources for treatment. They're not getting their prenatal care, which is going to have downstream consequences in worsening obstetrics outcomes. So all of these combined are what are leading to some of those things from our prior slide. I said that my hope is that we sort of address this from a trauma-informed or social justice lens. So I'm going to talk a little bit more about that. Many of our patients have a history of trauma, including violence and victimization. Those with substance use disorder, those without substance use disorder, but we know patients that are experiencing substance use disorder or have had a history of substance use disorder are disproportionately more likely to have experienced trauma. Trauma impacts our patients' lives, it impacts their behaviors, it impacts how they interact with systems, including healthcare. And beyond their personal trauma that they may have experienced during their lives, pregnant people and people who are reproductive age have had historical trauma that impacts how they approach care. So specifically, again, if we're thinking about in Montana, thinking about historical reproductive trauma to Native American populations in our country, in our state, and that may lead to people being less likely to want to access care because of fear. So when we're thinking about how we can approach a patient using this trauma-informed and social justice lens, these boxes are some things that I want us to sort of think about and carry with us. We should be aware of the role that trauma plays in a person's life. We should aim to minimize re-victimization. We should provide a comforting and welcoming and accessible environment for people who are presenting to care. We should assume unconditional positive regard. Again, we should assume people are wanting to make the best choices for themselves, for their families, for their babies, and they may not have the resources to be able to do that, right? But I don't think anyone is sort of approaching, hopefully, most people are not approaching pregnancy and parenting with not positive regard, right? We should empower and emphasize empower our patients and emphasize their strengths. We should respect a patient's choice and autonomy in the recovery, pregnancy, and birth. Patients may not make the same choice that we would make for them, but it is their choice to make, and we can be there and we can support that. And there's power in autonomy, and we should not create an environment where we are placing judgment or sort of stigma on people who are not choosing what we would choose for them. We should recognize, again, going along with that, our own bias that we bring into our interactions, right? And we should create mutual and collaborative goals that meet both our patients' needs and hopefully their healthcare needs. And we should facilitate recovery and healing. And the language we're using when we're talking to our patients matters. Historically, we have had sort of more prevalence in use of this, what I would call judgment forward language, when we really should be trying to use value neutral language when we're talking about patients with substance use disorder. So instead of saying substance abuse, we should be saying substance use. Instead of calling people addicts, drug users, junkies, they're people or persons with substance use disorder. Instead of saying IV drug user, we would say a person who injects drugs. Drug of choice, like somehow people are just making choices and deciding because it sounds like it's something that's a great idea. Substance abuse, right? Even terms like clean or sober can come with connotations, and things like abstinence, in remission, no longer using drugs are more appropriate. Instead of using the term dirty, you saying using X substance or testing positive for X substance. Instead of saying that someone has relapsed in their use, we'd say that they were returned to use. Instead of calling patients resistant, and this happens in substance use and in outside of substance use, we'll say patient is resistant to care. They decline care. They choose not to. They're not ready for. Instead of terming people unfit parents, we should talk about that they're experiencing barriers to success in their parenthood journey. And then instead of calling a baby addicted, they're a neonate with neonatal abstinence syndrome. We'll talk more about what that means. But this idea that a baby is addicted, so a baby who's born to someone who's using substances, addiction really is more of a psychological diagnosis. And a baby is not psychologically addicted to anything. They have dependence on or tolerance of, or maybe experiencing physical symptoms related to not being exposed to a substance, but they are not addicted. I also sort of as this framework, this is a lot of framework language before we get into the nitty gritty, want to emphasize that harm reduction is our goal. And this is a QR code that will take you to a great website whose name is escaping me. I think it's like the Harm Reduction Coalition or something like that. But remember that recovery is not linear. We said in its definition that substance use disorder is a chronic condition that is expected lapses, right? So recovery is not linear. We may have lots of good forward progress where we're in recovery for a period of time and then we experience a relapse, and that's okay. That's part of what we expect. And while abstinence from a substance is ideal, it may not be realistic and achievable for all of our patients and all of the people we're interacting with. So our goals should be safer use, reduced use, access to medical care, so that people can have the healthiest pregnancy possible. So even if we're using less, even if we're using safer, those are laudable goals, right? And if we can connect people to good care, and thank you, the perinatal harm reduction, Center for Perinatal Harm Reduction. So let's talk a little bit about, so now we talked about all of this framework for how we should be approaching patients with substance use disorder. How do we identify patients with substance use disorder? So a patient may come in and tell you, I'm using an opiate medication, or I'm using methamphetamine, or I'm using marijuana or alcohol, what have you. But that's probably not going to be the case. I mean, maybe sometimes, but if we just decided that we're only going to address or treat people who are telling us they were using substances, we'd be missing a huge swath of the population. So we know that substance use disorder affects a diverse population of patients, and it is often under-recognized and undertreated. So lots of people, there was a good number of people who said, I don't know about whether or not they're interacting with people with a substance use disorder, right? If we don't ask, we might not know. And we know that if we only screen based on risk factors, we're going to miss many people who could be linked to care and could benefit from treatment. And we're just contributing to stigma and stereotyping. And so there's been a big push to move towards universal screening. So instead of asking people who we think are at risk for substance use disorder if they're using substances, the American College of Obstetrics and Gynecology, who's really the organization who in our country sets sort of the standard for care in the obstetrics realm, recommends that we should universally screen as part of comprehensive obstetrics care at the first prenatal visit. So everyone, regardless of risk, we should be assessing for substance use. And we should be screening with a validated verbal screening tool that allows us to focus on supports for success instead of punishment to use. So here are a couple of examples of some verbal or paper screeners that you can do. The NIDA4 is, in the last year, have you smoked or vaped tobacco, had more than 4 drinks of alcohol in one day or more than 10 in a week, used a prescription for something other than it was prescribed, used an illegal or illicit drug, or used marijuana. And if someone answers yes to one of those questions, it's a positive screen. It does not mean they have a substance use disorder. It's a positive screen, and we should do a more thorough assessment. An alternative, which is something that is specifically been studied in pregnancy, was created for pregnancy, is the 4Ps plus. It's breaks things into 4P domains: parents, partner, past, pregnancy. Did any of your parents have a problem with drugs or alcohol? Does your partner have a problem with alcohol or drug use? In the past, have you had difficulties in your life due to alcohol or drugs, including prescription medications? And in the month before you knew you were pregnant, how many cigarettes did you smoke? how much alcohol did you drink, and how much marijuana did you smoke? And again, a positive answer to any of these should prompt us to have further discussions. It doesn't mean that they have a substance use disorder. It just means that we should be thinking a little bit more about this patient. I want to emphasize that screening for substance use disorder, universal screening, is not the same as urine toxicology screening. So when we say universal screening, what we mean is screeners like the NIDA4 or the 4Ps plus. We don't mean urine toxicology screening. Okay, they're two different things. And in fact, urine toxicology screenings are not recommended for routine screening. When we are doing urine toxicology screening, we should have a clear indication as to why we're doing it, right? We shouldn't just do it because we feel like we should or because it's part of our standard thing. We should do it because someone's presenting with preterm labor and that could be something that could cause someone to have preterm labor, or we think someone is having a placental abruption, or maybe there's fetal growth restriction and we're concerned about the sources of that. And we should never, let me rephrase this, we should always have explicit consent to do the screen. We should never just collect people's urines and send it for a drug screen without people's consent. Some people may say, well, they might not consent. Why would they consent? Okay, that's a choice, right? That's autonomy that we have to support. And then we can change the way that we are addressing our treatment, maybe by making a presumptive diagnosis. We should never send a urine toxicology screen without someone's consent. Urine toxicology screens are disproportionately used in BIPOC patients and in poor women, and disproportionately those people have results that are used as part of child removal. So that's in and of itself a reason not to use it, but that's an important point. We should also remember that our point of care tests, and even as a patient shows up on labor and delivery in the hospital and gets a urine drug screen, those initial tests that we're running even in a hospital lab have high false positive rates and high false negative rates, and these can lead to false assumptions. I was doom scrolling, and there was some article about a woman who had eaten poppy seed bagel before she went into labor and then had a urine tox screen and her baby was removed. I don't even know if this is true, but like, this is legitimate real things, right? Like that could happen to a person. There is a high false positive rate on these screening tests that we do, and we would need to know that if we're doing them. Confirmatory testing should always be used if we have a positive point of care test. And the one place that routine screening may have an appropriate role is in compliance to follow up for medication-assisted treatment. So if patients are on methadone or buprenorphine, and we'll talk about that more in a little bit, there may be a role for doing testing to make sure that patients are taking the meds that they were prescribing them and they're not diverting them. Question about, do you have to by law notify CPS if there's a positive urine toxicology screen? Good question. And we're going to get to that towards the end. Good question. And a reminder that, again, another reason, if this wasn't enough reasons for us to not use urine toxicology screening as a screening test, urine toxicology says nothing about the severity of use, the chronicity of use, and it's just an incomplete assessment. So someone might have used once several hours ago. They may be using chronically. If someone's chronically using fentanyl, that will stay in their system a lot longer than someone who just used it once. So it says nothing about even the timing of use for most patients. For many patients, not most patients. When we positively identify someone on one of our screeners, we should be using what's called the SBIRT model. So that's screen, brief intervention, and referral to treatment. With this, the idea is that we should collect a comprehensive substance use history. We should screen for high-risk behaviors, including injection use, exchange for, oh my gosh, let's see if we can just move this down. Exchanging sex for drugs, interpersonal violence, mood, like anxiety and depression, and trauma. We should identify and address barriers to care, such as housing, transportation, access to food, insurance. And we should discuss options for medication treatment for substance use disorder and refer as desired. Oh, there we go. Okay. Patients who do have substance use, when we're providing prenatal care to them, we should do routine STI screening just like we would do for everyone else in the first trimester, and maybe consider adding STI screening in the third trimester if they have ongoing risks. We should screen patients whether or not they've had the hepatitis B vaccine and give it to them if they're not immune and they have ongoing risks, such as IV drug use. We should consider tuberculosis testing in patients with risk factors. So patients who have been incarcerated we should screen for tuberculosis. We should consider getting some additional lab work to make sure there's not other medical conditions that are complicated from substance use. We should maybe engage with our high-risk perinatology specialists, pain management specialists, other specialists. We should get potentially some additional screening later in pregnancy in the third trimester. And all patients with opioid use disorder should have naloxone at home. And this is something that, regardless of what type of work you do in the healthcare field, is a recommendation and something that we can all action on. Naloxone should be available at pharmacies without a prescription. It's available at many public health departments without a prescription. We can stock it through our different agencies and administer it too. And so naloxone is important and it saves lives. Even if the patient's not currently actively using, or the person that we're working with, they likely have people in their lives who maybe are still actively using or at risk for overdose. And then we should be talking with our pregnant patients and the people we're working with about the potential legal risks, substance use disorder, and their ongoing risk. We should discuss how trauma may present in the delivery room. We should discuss peripartum pain management, and postpartum, we should discuss what it would look like for infant care and breast or chest feeding, if they so choose to do that. So the rest of our talk is going to be sort of through the lens of several different patients or cases, and I just think it's the best way to illustrate some of these concepts that we're going to be talking about. These are not inclusive of all the types of presentations of patients with substance use disorder and pregnancy, but hopefully touches on a lot of our high points. So Casey is a 30-year-old. She's had 3 pregnancies. This is her 3rd pregnancy. She has 2 prior babies. She's 16 weeks pregnant, and she is coming for her first prenatal visit from the jail. They are coming from their first prenatal visit from the jail. They have a past medical history of tobacco use and current everyday fentanyl use. They do not have custody of their 2 children, ages 6 and 10. This pregnancy was unplanned but desired. They actually did try to present to care earlier than 16 weeks. They went to a local OB office at about 6 weeks to establish care, but they felt judged by staff, and the provider told them they don't treat addiction there. They subsequently tried to quit on their own, but were not successful. They expressed desire to be in substance use treatment and to parent this child. They have already gone through withdrawal in the jail, but fear return to use when they're released shortly. Casey wants to know, what are my options for treatment? Amber is a 30-year-old. This is also her 3rd pregnancy, and she's had 2 prior deliveries. She's at 20 weeks, and she is coming to you to start medication-assisted therapy. She is married. She's a mom to 2 older children, ages 6 and 10. She has a past medical history of depression and recurrent kidney stones and some chronic pelvic pain. Early in pregnancy, she experienced kidney stones and was prescribed an opioid pain medication for about 8 weeks by a combination of her obstetrics provider and several emergency room physician providers. Ultimately, when she stopped taking this medication, she experienced withdrawal symptoms. And she was referred to you from her obstetrics provider. Looking through, most states now have some sort of prescription drug registry. Montana has one, and it allows medical care providers to look and see what prescription controlled substances someone's been prescribed, who's prescribed them for how long, when it was dispensed, etc. When you look through, you see that she's had numerous prescriptions for opioid pain medications and benzodiazepines, which is an anxiety medication, for multiple providers over the last 9 months. So more acute early in pregnancy, but if you look back, this has been going on for some time. And she's currently on sertraline, which is a medication for mood. She wants to know, what are the side effects of going on medication-assisted therapy for her baby? Hera is a 30-year-old, again, has been pregnant 3 times, has had 2 prior deliveries, and she's 10 weeks, and she's here to establish prenatal care. She has a history of opiate use disorder, in remission for 4 years, and has been stable on methadone. She also has a history of hepatitis C that was treated in the past. This was a planned and desired pregnancy. She has 2 other children. They were both delivered via C-section, and they were adopted out when she was still using, and she doesn't have contact with them. She's currently on 170 milligrams of methadone in the morning and 120 milligrams of methadone in the evening. She wants to know, should I come off my methadone to avoid any potential side effects for my baby? Should I switch to buprenorphine? Should I lower my dose of methadone? And we're going to talk about medication for opioid use disorder, or MAUD. And I know that most of the people sort of on this presentation are not prescribers or direct to care providers in the way that they would be maybe initiating people on treatment. But I think it's really important for us to know what our patients may be on or may be considering taking, and to know the facts, because there's a lot of false information that exists about these medications and about the way we treat opiate use disorder outside of pregnancy. And particularly, there's a lot of false information about pregnancy. And I have been shocked about how much even healthcare providers do not know the actual data and the evidence and provide false and actually harmful information. And so I think if we know the appropriate information, regardless of sort of our scope of work, we can provide sources for correct information to support people. We can provide support for people. And when people are encountering non-factual information, particularly from the healthcare field, can help people recognize that that may or may not be true, and so that they can ask the appropriate questions. So the mainstay of treatment for opioid use disorder in pregnancy and outside of pregnancy is opiate agonist therapy. Methadone or buprenorphine, Suboxone or Subutex is the brand name that people may be more familiar with, are the mainstays of therapy. Neither of those medications show an increased risk of birth defects or changes in child development. And the MOTHER study, which was a very large study that looked at use of both these medications in pregnancy, showed that it decreased withdrawal and risk-taking behaviors in pregnant persons. It lessened the likelihood of return to use. By being on an opiate agonist therapy, people had improved adherence to prenatal care and substance use treatment. They decreased their risk of infection exposure. They improved maternal nutrition and improved neonatal birth weight. So all positive data, nothing showing harm from these medications. There are some alternatives to methadone and buprenorphine, like medically supervised withdrawal, which we do not recommend because the rate of relapse is really high, and there's a high increased risk of overdose in patients who have withdrawal from medications. And we'll talk a little bit more about that. But basically, patients, how is MAT different than MAUD? Great, just different terms. MAUD is the term specifically that talks about opioid use disorder, and MAT just is in a sort of more general term for substances of any kind, but basically they're the same. And then there are some opiate antagonists like naltrexone or Vivitrol, maybe a term that you've heard, that comes in an oral or injectable form. We just don't have a lot of data on its use in pregnancy. And in general, we think of it as less successful when we compare it to methadone or bup. And so that is our mainstay. Also, being on naltrexone requires that you withdraw first. But some patients, this is what they've been on and they've tolerated it well, and request to be on this, or they haven't done well with other medications. And so it may be an option in discussion with a healthcare provider. So I'm not going to belabor this again, because I don't think this is really sort of like the goal for the rest of our talk, but there are some pros and cons to both options as far as why someone may choose one or the other. Methadone has to come from a methadone clinic. So you have to go to an actual place that prescribes methadone. And in our more urban areas of Montana, we have access to that. And on our more rural and frontier communities, we just probably don't have access to that. And so methadone may not be an option for many people in our state in particular. The advantages are it has a much wider dose range, and that controlled environment of going to a place to get your medicine on a sometimes daily basis for people who are initiating medicine is just some extra wraparound support that many people would benefit from. But it does have more drug interactions. Like we said, it may be hard for people to access. And we talk about neonatal withdrawal, it may be more significant, people with methadone versus buprenorphine. Buprenorphine or Suboxone Subutex can be prescribed by any healthcare provider who has a DEA number. It used to be that you had to do a separate special licensure for it, and that went away in 2022, 2023. And so now anyone can give it. And usually we use the standalone product buprenorphine in pregnancy and the combination buprenorphine naloxone outside of pregnancy. But there's lots more data on using the combination product in pregnancy. And so patients should stay on what they've been on, and it's fine to use the combination product. And that's a longer conversation as to why. There's also some transdermal options like a patch in injectable form, but we just don't have as much data on that. And the advantages are, again, you can get it from any healthcare provider. So if you live someplace that doesn't have a methadone clinic, you still hopefully have access to this. Babies may have less with severe withdrawal symptoms from it. The disadvantages are, though, that there's just a narrower dose range and it may not work for everyone. And patients need to have a little bit of withdrawal symptoms in order to start it often, which some people may not be able to tolerate. Regardless of what treatment people decide to engage in, we should treat to resolution of withdrawal symptoms and reduction of cravings. We do not want to undertreat because that's going to increase our risk of return to use. And so we need to treat people appropriately. We shouldn't gatekeep how much they're on if they're really still having symptoms. We should not taper doses in pregnancy and because that increases our risk of return to use during pregnancy and the postpartum period. And this is, I would say, like a common myth that I've seen perpetuated is by healthcare providers and just in general that we should be on a lower dose, or we should stop it during pregnancy. And all of our data says that's not true. Patients should stay on the dose that they're on in pregnancy. And in fact, many people need to increase their dose in the second and third trimester because of the changing pharmacokinetics of the medication, that they will need higher doses in pregnancy. And specifically when we're talking about fentanyl, which we're just assuming almost everyone is using fentanyl, we're going to need to do higher doses. And there's some different ways we can dispense that and dose that when we're starting people on it, because fentanyl is its own whole different thing. And then another important thing is we should stick with one medication to reduce side effects. So similar to when we were talking about medications for mood last week, stick with the one that brought you. So if you're on bup to start pregnancy, stay on bup. We should not switch. I've also seen that perpetuated, that methadone is worse because you're going to have worse withdrawal symptoms from your baby. And so we should switch you to buprenorphine. No, not true. Stay with what you're on. In an ideal world, medication therapy is partnered with counseling support, but that we don't live in an ideal world, and not everyone have access to counseling, and not everyone will have the time and resources to access counseling, or just not available anywhere where you live. And so medicine is better than nothing. And so medicine alone is okay. We used to say for bup, people had to be engaged in a 12-step program or say that they had a counselor, all these things. We don't do that anymore because something is better than nothing, because harm reduction is our goal, right? So back to our patients. So Casey is started on 8 milligrams of buprenorphine twice a day. At 30 weeks, she has a return to use, and she has a lapse in her prenatal care for about 6 weeks. She goes into labor spontaneously at 39 weeks. Amber was started on 8 milligrams of buprenorphine twice a day, and in her third trimester increased to a total of 24 milligrams daily. And she's induced at 39 weeks for gestational hypertension. And now I'm forgetting what the name of my last patient was. Shoot. Was continued on methadone with a dose increase in her second and third trimester, and she's scheduled for a repeat C-section at 39 weeks. They want to know, am I going to be treated differently because of my history? Can I still get an epidural even though I'm on these medicines? Am I going to be able to get pain medication for my C-section? These are real questions, and problems and concerns that I run into with my patients. So when we're talking about in labor management, we know that patients who on medication assisted therapy have an increased opioid tolerance and a higher sensitivity to pain. So we know that we need to dose them much longer and higher than someone who is opiate naive. And the same goes for someone who's presenting with active substance use. They have an opioid tolerance because of what they've been taking. And so we are going to have to give even more medication in order to overcome what they're already taking to treat their pain. What they've been using, their methadone or their bupe, or even their illicit substances, is not a replacement for pain medication in treatment of a medical condition. Right. Some people even get pain medication after delivery, even if it's not a C-section. We should ideally, if we're seeing these patients before delivery, be discussing this and what our plan for pain management is prenatally. We should continue their maintenance dose of their medications during labor and postpartum. We could consider breaking it up into more small doses throughout the day to help with pain management, but we don't give them additional doses because that's not what it's used to treat a medical condition, not used to treat their pain in this particular instance. Patients can still get epidurals or spinal anesthesia if they want. And again, if we are going to be giving IV or pain or PO pain medication, particularly opioid pain medication, we're going to need higher doses. One study showed people on buprenorphine undergoing a C-section required 47% more opioid analgesia. We should consider doing some alternatives, such as an epidural or intrathecal morphine if someone has a C-section, to give additional pain relief, or some other types of procedures to give them additional pain relief, like a TAPS block. Patients may benefit from a PCA, which is basically a pump that they control that has some barriers to it. You can't just give yourself medication to oblivion, but for post-op pain control. And we should maximize non-opioid pain medications, like maybe using NSAIDs or gabapentin, Tylenol. And then we should avoid any partial agonists in labor. Treating pain does not increase the rate of relapse. In fact, undertreating pain increases the rate of relapse. So someone is not having adequate pain management, they get discharged from the hospital, they're in pain, they're not doing well. They may decide to return to use in order to treat their pain, right? And so we want to make sure that we are not undertreating because we are increasing the rate of relapse, really. And then we should know that the babies of birthing persons on MAUD are going to have some fetal heart rate tracings that may be less reactive. And for people who work on labor and delivery, I saw there were a couple nurses here. That just means like we may have a less reactive strip, and that is okay. Just like if we gave someone opioid pain medication in labor, we expect that baby to look a little sleepy on the monitor. Babies, specifically methadone in particular, more than bupe, may look sleepy on the monitor. Someone said, one of my biggest fears is if I get into a wreck or something bad happens and it's painful, what am I going to do? Am I going to die of pain? Those are the fears you have. Yeah, for sure. I mean, that's awful that those are fears that you have to have, right? Are there non-pharmacological pain managements that I recommend in my practice? Yeah, I think we talk about sort of, especially in labor, what are some things like meditation? There's fancy things like hypnobirthing, hydrotherapy, doula support. We're not using the word doula anymore, because it's related to a connotation of slave. And someone at a presentation I was at recently used this amazing word that was something, birth witness, was their suggested alternative, birth witness. Having a birth witness for support, we know decreases pain in the intrapartum period. There's lots of different things that we can talk about. Yeah. Probably not so much for post-procedural pain, like when we're focused on the sort of active birth, there's lots of things. And then for post, trying to use non-opioid things to maximize. In addition to opioids, we're never going to replace them. Again, sort of harping on this for a second, and the fact that we're going to know we need higher doses. Again, this is a place that I commonly have gotten pushback or just have heard false things, is that like, well, we're just giving so much meds, we're just going to make them unconscious, or they're not, this just seems like too much. It just seems like more than what's appropriate. And that's okay. That's someone's opinion. And we have data to back it up. 47% more likely, more volume of pain medication is going to be needed. And if we don't treat people, they're going to act like they're in pain, which people oftentimes interpret as drug-seeking behavior. Like if we're in pain and we're asking for more medicine and we already have this bias that this person is a drug user or they're seeking drugs, right? We're just going to be actually self-affirmed by undertreating their pain that their behavior is drug-seeking. And so we're just in this loop. So back to our patients. Won't my baby withdraw when they're born? How long will I be in the hospital? Will I be able to stay with my baby? What can I do to help my baby? So neonatal opiate withdrawal syndrome, or NOWS, NAS is an older term that you may have heard too, is an expected and treatable condition. Again, remember, expected and treatable, that is seen in 30 to 80% of infants born to a parent who's on an opiate agonist therapy, or is using illicit opioids, and is higher in patients with untreated opiate use disorder. So it's less likely to happen, or is going to be less severe if we're in treatment than if we're continuing use. And usually presents within the first 5 days of life. The onset may be a little bit earlier with methadone, later with buprenorphine. Like we said, methadone, it may be more likely to occur, but actually the dose of medication does not correlate with the likelihood of onset or severity. And again, that goes back to like this misinformation that we should be on a lower dose or we should taper. There's no data to support that. In fact, there's all the data to support the exact opposite. So people should be on the dose that is appropriate for them. And that is individualized to each person. You cannot compare, you have someone who's 90 pounds pre-pregnancy, 190 pounds pre-pregnancy. They may be on totally different doses. It's nothing to do with body habitus or size or how much, anything like that. It's so independent. So we said NOWS is really specific to opioids. We do still use the term NAS, or neonatal abstinence syndrome. The reason why there's two different terms is that actually can apply to a lot of different things. SSRIs can have some amount of neonatal abstinence syndrome. We're not telling people to stop their SSRIs. Nicotine definitely for sure can cause it. Alcohol, benzodiazepine, stimulants. We're going to see symptoms of that baby not be exposed to that anymore, or withdrawal essentially is what we're seeing. And because we know other things can also cause similar symptoms to NOWS, we should encourage titrating off of co-occurring substances when appropriate, not SSRIs. Don't tell people to stop their SSRIs, but if someone is using opioids and nicotine or other substances, and we can decrease how much of the other substances they're using or stop them, we're going to be in a better spot. And also, patients who especially are early in remission for opiate use disorder may or may not be in a position where they're able to stop things like nicotine and be able to go about their daily lives. And again, harm reduction, meet people where that. Infants, we typically keep them for 5 days for observation of NOWS after birth. And if they don't experience it during that time, they get discharged. And if they do, they may stay longer. But that's just information for patients to know. And hopefully we should be talking about this ahead of time with them. Their healthcare provider should be. Things that we would look for is babies may be irritable, jittery. They might have a high-pitched cry. They may not sleep well. They might have an uncoordinating suckling reflex, which can contribute to poor feeding and weight issues. They may have some instability in their temperature. They may sneeze a lot. They may have a fast heart rate or fast breathing rate. And we used to treat with this old sort of treatment modality called Finnegan scoring, where we would score babies and we would say like babies are sneezing or babies are jittery or babies are crying or babies aren't sleeping well. And so they meet some criteria and we're going to give them medicine. And what we realized was it was very subjective. Like if you took a bunch of different people and had them rate the same baby, they gave different numbers. And also the problem with that too is it like complicated or like overrepresented some of these symptoms that weren't even related to opioids, right? Maybe some of these other meds. And so now we use this in most places. Eat, Sleep, Console is sort of the way that we approach NOWS for babies. If you are at a facility or you're in an area where you know your hospital's not using it, this would be a great place for advocacy because this is evidence-based. It reduces hospital days, which reduces cost. It uses less medication. It's safe. And it prioritizes the idea of newborn milestones. And its idea is that it focuses on the family unit being part of the healthcare team and harnessing what we all want to do for our babies to comfort them and support them and help them through this transition. Because that's what it is. We're helping them through a transition, just like the transition from never breathing because you were just getting oxygen through your umbilical cord to breathing, right? It's a transition. I'm not going to belabor eat, sleep, console, both for time and again, I just don't know that it's as applicable maybe to our audience unless people are like, yes, spend time on this. But again, the idea is that we want to harness the families and the parents, the things that they can do for their baby and prioritize that. And so that's thinking about things like low stimulation environments, dim lights, reduced noise, minimal visitors. We're not gonna wake the baby to do all this stuff for them and make them angry and then be like, oh, they're jittery because we woke them up. We are gonna try to harness things like autonomic soothing. So the way that a baby would automatically want to soothe themselves. So rooming in, skin to skin, swaddling, holding, cuddling, rocking. We call kangaroo care, which is basically like baby wearing essentially. Non-nutritive sucking like pacifiers. There are roles for pacifiers in baby care, and this is one of those really good ones. And then encouraging breastfeeding, which we're going to talk a lot about. And basically we're looking, can a baby eat, sleep, and console what is developmentally appropriate for newborn? And if they're not, we say, okay, how can we do the first set of things better? And if they're still not doing those things, then maybe we give medicine. But the patient is part of the healthcare team, which I think is really empowering for people, that they are part of this journey too, and they're not being sidelined. So our patient wants to know about breastfeeding. One of our patients says, I've never breastfed my others before, but I would like to try. Am I even allowed to breastfeed on this medication? I breastfed my other children and I want to do it this time too, but I'm afraid that my milk is going to be bad for this baby because of the medicine. Because I used, how long do I have to wait to breastfeed? And will they tell me I can't breastfeed at all? So breastfeeding and opiate use disorder, a level 2 evidence for supporting this is that breast or chest feeding should be encouraged in patients who are stable on their opioid agonist therapy or other patients with substance use disorder in remission. Okay. And this is a departure from older recommendations. This is like from a recommendation from American Breastfeeding Academy in 2023, I think. But we should encourage it in people who are stable and even people who have substance use disorder that are in remission on agonist therapy or not. And that's because breast or chest feeding is beneficial in lots of different ways. It's beneficial for parent and infant bonding. It helps reinforce as a positive reinforcement for the birthing parent's substance recovery. It's associated with a decreased severity of NOWS by about 30%. The milk is medicine. The milk has a small amount of their medication in it, and so we're giving babies teeny tiny doses of their medicine to decrease the likelihood of withdrawal. It decreases hospital stays by 50%. And there is a lot of, what I hear is a lot of concern still about providing breast milk of someone who's on methadone or bupe or even pain medication for post-op pain to babies. But the transfer of opioid medications, period, and in particular, methadone or buprenorphine, is very, very low in milk. So it's like 1%, 2% of what the parent is taking is going into the breast milk, teeny, teeny, tiny baby doses. And even the American Academy of Pediatrics, who again, if we're thinking about like the people who make these recommendations in our country, recommend breastfeeding regardless of the maternal dose. So what I have heard, again, false information is like, that dose is too high. Like, okay, normally we would let it, but like this dose is too high, so we can't really allow it. Regardless of maternal dose, we should still support it because the baby was getting way more in utero, not the same amount as mom, but way more in utero than they are through milk because so little of it passes in the milk. And baby did fine. And baby's used to that. Baby is accommodated to that. And so, I mean, yeah, I probably wouldn't love giving someone like suddenly like, comatose doses of an opiate that they never had gotten before, right? and then giving that baby that milk. But that's not what we're talking about. We're talking about someone who's been on this medication for a long period of time and their baby's already been exposed to it. We're actually going to cause harm by denying that breast milk because we're going to worsen potentially the severity of our NOWs. So the recommendation is that on opiate dosing is that we should give it regardless. There are lots of practices or policies that say that like we should have maximums of how much someone can be on, that we can still give them breast milk. And that's really not evidence-based. And again, does not apply to opioid tolerant birthing persons. Okay. This is talking about someone, again, who is in remission, who is stable. Individuals who discontinue use of a non-prescribed substance by the time of delivery should be supported in breast and chest feeding. The data supports that people with discontinued use by the time of delivery are likely to stay in remission and have discontinued use. In the case of someone who does return to use at some point during their breastfeeding or chest feeding journey, we should counsel them that they should not be breast or chest feeding if they're continuing to use, but we should support them in pumping and maintaining their milk supply, and therefore being able to go back to breast or chest feeding when they're no longer using. So if we stop pumping or providing milk entirely, it's kind of a lose it or use it situation, with breast milk. So people can continue to pump. We should get rid of that milk. We shouldn't give it to a baby, but once they are no longer using and they're substance free for the appropriate amount of time. And that really kind of depends on what substance they're using. Generally, we say 48 to 72 hours, a little bit on the longer side for fentanyl, like at the 72-hour mark, probably for fentanyl use. Then we can go back to using milk. So we're going to meet a new person, Kat. She is also a 30-year-old who's had, this is her third pregnancy. She's had 2 prior deliveries. She presents to labor and delivery in active labor at 35 weeks, so a little bit early. She had entered prenatal care late, about 16 weeks, and she has missed several appointments. She has past medical history of substance use and was seen actually in your clinic by another provider who doesn't do prenatal care shortly before becoming pregnant, and she was started on buprenorphine, but she didn't end up continuing that care. During her prenatal care, you know about this history, but she reports being in remission since early pregnancy. But when she presents to labor and delivery, she reports that, in fact, she's been using fentanyl daily for most of this pregnancy. She gives birth to a 5-pound, 6-ounce baby later that day, and the baby is admitted to the NICU for some breathing issues. Shortly after her birth, Kat expresses that she would like to be started on methadone. And she's been thinking about this for a long time, but she reports being afraid to access treatment during pregnancy and to admit to use during pregnancy because she thought there was maybe a chance that the medication would harm her baby. But more than that, she was really concerned. She has custody of her other children, and she was concerned that if she presented to care and was truthful, that it would jeopardize the custody of her other children. So on the day that she delivers, you start her with 30 milligrams of methadone. And you start to taper her up every day until discharge, and she follows up with an outpatient methadone clinic on discharge. Kat wants to know, are they going to drug test me and my baby? Is CPS going to take away my baby? And so let's talk about reporting. I know I had a question about that earlier. So many patients harbor fear that social services will become involved in their pregnancy and in their parenting, and they fear criminalization of their use in pregnancy, and that often impacts their willingness to present to care. The reality is patients who present earlier and get treatment are in a much better position as far as engagement with social services and ability to continue to parent, but I think that there's so much fear that people don't really understand or see that sometimes. And we'll talk about, I'm going to skip the point of toxicology in a second. Healthcare providers do have a reporting requirement and should be transparent to patients. People that are not direct healthcare providers are not the same in their mandated reporting. So you should check, depending on what type of licensure you may have, whether or not that does apply to you specifically. healthcare facilities are required to report, healthcare providers are required to report. Like not every single person who interacts with that patient has to report, but like there has to be a report usually. And that's based on the CAPTA, which is Child Abuse Prevention and Treatment Act, which requires, it was a federal act that required states to have policies and procedures requiring healthcare providers to notify Child Protective Services if they're involved in the delivery of an infant born being identified as being affected by substance abuse or withdrawal. So that's not actually very clear. Like that, I don't know. I don't totally understand what that means. So in Montana specifically, because the federal law said states need to make laws, so Montana made a law, and their law is that healthcare providers must notify CPS, which is our agency here, of all infants born and identified as being affected by illegal substance abuse, withdrawal symptoms from, again, illegal substances, resulting from prenatal drug exposure or fetal alcohol syndrome. They specifically call out because obviously alcohol is not an illegal substance. So marijuana is legal in Montana, so we don't need to report marijuana, is my interpretation of this. If there's someone who's on who knows this and understands this more, I would love your input. But my understanding is things like marijuana, which is not an illegal substance in the state of Montana, does not need to be reported. And patients that are on MAUD or MAT do not need to be reported because it's not an illegal substance, it's a prescription medication. Some states have not had that specific illegal term in their wording. And so in some states, actually, you may still need to report someone who's on MAT or MAT, but in Montana, we do not need to. And I want to, this has been said to me because I think everyone feels there's a gray area. There's like, we know this is bad and I need to report this. And there's like, ooh, I don't know, should I report this? Like, I think those spaces both exist. And something that I think has helped me in figuring this out is notification, required to notify, is not the same as saying that you suspect abuse or neglect. So you're just saying, this is the information that I have, and it is the agency's job to investigate if there was abuse or neglect, right? You just have to report the thing. So that has helped me a little bit. Amy asked, so only notified during birth, not while someone's pregnant. Kind of, yeah. So what we have taken this to be is I don't typically, unless I'm concerned about something that's actually happening that may affect someone while they are pregnant, typically we do not report until delivery. Right, CPS can't intervene until the baby's born. Exactly. So, but again, we should be talking to patients about the fact that we may need that this is something that's going to be a part of their reality, unless there are other children in the home. Yeah, unless we're concerned someone's actively using substances and there's other children in the home, then we might need to report then. Or the expectant parent is a minor. Great. Look at all of these people who know so much more than I do on this, because this, I think, is confusing to lots of people. And so I would ask if you work at a hospital, what their specific policies are. Like oftentimes, like I know at our hospital, oftentimes it's the social worker that's doing the CPS report. The individual provider doesn't need to. I have been the person who reports when it's been a particular instance and I'm afraid someone's going to get discharged on the weekend and the social worker's not there. And like, I know that it's something I have to do, for instance, like let's say someone was using and is no longer using at the time of delivery, but like they were, and there's some impact from use of illicit substances. And so that might need to report. And so like, I feel like I want to be able to give all the information, but oftentimes it's social work. Coming back to toxicology screening, we talked a lot about urine tox screening. There's also, we can do toxicology screening on cord segments, on the placenta. We can collect urine toxicology from babies immediately after birth or in the immediate few hours or days after birth, because that may reflect the birthing milieu.
So that hose right there for your washing machine was laying it down. Oh, it wasn't connected? Well, it was connected.
I think someone's unmuted. Good. Okay. So there are lots of different types of toxicology we can do. And I think different people have different opinions on toxicology screening, but what I have sort of, if someone's reporting use, like I don't need to confirm that they've reported use. Like they're probably not lying to me about what they've used, right? Like they're reporting some amount of use. And unless like somehow knowing the real granularity of that's going to change something, I don't really feel the need to like do that extra stuff. That's just extra information that I don't really need to act on. If someone's declining testing or they're denying use, but you still have a high suspicion, and we said we cannot, without consent, test a birthing person, we may want to collect samples on baby because that may be important. We report marijuana positive to CVS, even though it's legal, because it's not safe at every level during pregnancy, considered similar to alcohol. Yeah. I think that that's a completely valid thing. We don't actually know what the safe dose of marijuana is. That's a totally different talk that I don't think I'm qualified to give, but marijuana is its whole beast. You can collect baby without parental consent. Yes. So now we are after delivery, postpartum, such great questions. Yes, keep them coming. Our patients want to know. Okay, I know you said I shouldn't go off my meds while I was pregnant. I totally got that. But now that I'm not pregnant, can I stop them? The reality is postpartum is the time of highest vulnerability of return to use. And so we definitely, in the immediate postpartum period, want patients to stay on their medication. The data shows that the highest risk of death from overdose is between 7 and 12 months postpartum. So we have this initial postpartum like rush of great things, new baby energy, and then we're back to our routine. We may have a higher risk of return to use. Also, I think we identify a lot more PMADs early. I mean, we're not great at identifying it, but what we do identify is usually early because people are still wrapped around in their obstetrics care. And then later on, we sort of forget about it. And so patients don't even know that you can have postpartum depression or anxiety later. And so there's sort of this roll in of depression, anxiety, and substance use disorder, and increasing our risk of death from overdose. Again, we should make sure patients have naloxone on hand, and we should include it as a discharge medicine even. We should engage patients in wraparound services and resources to improve their transitions to home. Despite the potential for despite the fact that we may have increased doses during pregnancy, we don't need to taper them immediately after delivery. Like we should do that slowly as people's are readjusting. So usually it'll be over the first couple months that we taper them back to their pre-pregnancy doses. We don't need to do it immediately after birth. We should continue MAUD for at least a year after delivery, again, based on the data that I just talked about. And we should also think about the fact that unintended pregnancy rates are higher, about 80% in patients with substance use disorder. And so we should discuss contraception as an important part of recovery and stability. Discussing is not the same as coercion. I want to make that very specific. Again, we talked about like the reasons why people may have concerns or not really want to engage in healthcare, and reproductive coercion is one of those. And patients that are seen to be less fit to have additional pregnancies are at higher risk of experiencing reproductive coercion. So we should discuss it because we know it's a higher risk, and it's ultimately up to the patient what they wanted to do. Rates of PMADs and suicide are higher in patients with substance use disorder. We should remember to screen our patients or our clients regularly. And in an ideal world, we would have access to co-located treatment and family housing and supports to help decrease the rates of return to use and keep families together. And that's just not the reality for 99.9% of the people in the world, and in particular in Montana. And so there are some resources for people who are especially really early in their recovery, but those resources are quite limited. But think about them. So in summary, all pregnant and birthing persons, regardless of substance use disorder, should be treated with respect, autonomy, and treated appropriately for their pain, intra and postpartum. We should avoid punitive responses to perinatal substance use and honor the road to recovery while preventing perpetuation of further harm. Pregnancy and birth can be a transformative experience for all patients, including those who experience substance use disorder, if we support it properly. We should recognize that recovery is not linear, and our goal is to reduce harm and to support patients through the transition of recovery, pregnancy, and parenthood, and provide resources to allow them to be successful. We should train our staff to support trauma-informed social justice lenses in caring for pregnant patients with substance use disorder. And that includes knowing what's real news and what's fake news and what the real data says and what we hear, right? Just so that we can sort of arm people to address that. Patients with current use of non-prescribed opioids should be referred for MAT or MAUD, which, again, any provider who has a DEA license can provide buprenorphine. And while ideally we start while someone is pregnant, patients with opioid use disorder who are not being treated and present in labor should be offered treatment as part of their delivery hospitalization. And we should adjust our clinic and unit policies, if you're working in that type of environment, to be in line with this evidence-based therapy and recommendations, including guidance on NOWs, breast and chest feeding, and evidence-based pain management. So that is what we're going to talk about today. Here's some references. And what are you currently doing? What would you like to change? Any other questions?
So you said that treating the pain doesn't increase the risk of relapse. And I'm going to go down the podcast rabbit hole, so I apologize. But on, listening to podcasts about opioid use disorder, they'll talk about how, someone will have surgery and they'll have been in relapse for a long time, they'll have surgery, and then that will lead back to use again. Can you talk a little bit about that?
Yeah, that's a really good question. So, I think it's probably a broad overstatement to say that it can never happen, right? I think for some people, being on opioid pain medications may sort of harken back to when they were using these things illicitly and the way that they felt, or maybe triggering and bringing back memories or experiences that they had in the past. And definitely, I think that psychological component, I could see putting some people at risk of return to use. But the fear that that could happen shouldn't mean that we undertreat people's pain that they have from a legitimate medical procedure. And in general, I would say, we as a society don't generally take women's pain very seriously. We definitely don't take women of color's pain seriously. We definitely don't take poor women's pain seriously. And so we have a history of, in particular, obstetrics, but in all sorts of ways, undertreating people's pain because we think that they're being hysterical, or they're making it up, or they're just drug seeking or whatever. And so we really run the risk of causing harm by doing that. And so I will say, I definitely have patients who are undergoing orthopedic surgery, for instance, or other things that we talk about ahead of time. They're like, I do not want to do opioids. I'm not going to do it. It is important to me not to do it. I will do anything else, and we will talk about alternatives. And so I think that's why it's important, if you have someone that you can talk about before they have their baby, what their hopes and wishes are, right? Because we can try to honor that and be a little bit more preemptive with it. And definitely there are people who, I see people who have a C-section and take some ibuprofen and are fine. And I see people who take days and days of opioids, and it's not about someone being kind of a weenie about it, right? It's just everyone's experience of pain is different. So I think that's where that sort of statement comes from. And by undertreating people, just like by treating people, we may be triggering sort of this return to use. By undertreating people, we're definitely putting people at risk for that. So it's the known versus the possibility as far as weighing some of those. But such a good question. Yeah.
Hi, I have a good quick question, Dr. Greenberg. When you mentioned in your presentation about moving to a trauma-informed and social justice lens, how are you able to bring along other healthcare personnel within the organizations that you are working?
Yeah, I think that's a really good question that I definitely am not the expert on. Or do I know that I have the right way? I think to some extent it's showing up as an advocate. It's sort of volunteering time to say, let's talk about these things in a larger venue, right? for me, it's like, let's do a grand rounds and talk about opiate use disorder. Let's get a bunch of people together so they can hear some of this information. Let's be involved in some of our policies that we're putting together, right? So that there's a voice on those that is coming from it, from these lens, and I can sort of continue to talk about this. I think in reality, despite those things, and like, I'm sort of in a weird position in that, like, I'm not actually on the medical staff of the place that I deliver at. I'm just a doctor who has privileges there. And so I'm not like in this position of power per se, that when I have a patient who has a history of substance use disorder, like I am sort of trying to do some little grassroots, like when I'm working with nurses or working with lactation or working with the NICU providers, like trying to provide this information in real time, which is variably effective. And I think it's in my place of work where I do have a little bit more control. It's about like doing education with staff on like what kind of terminology should we be using? What resources should we have for people? How do we change our practices for prescribing to be more of a harm reduction model? How can we integrate these things into our screening forms and the questions that we're asking people? I think it looks really different in lots of different places, and you can be creative about it. And yes, are we having a session on that at the conference? That'd be amazing. Like, how do we promote this and push this? Because I want to hear from other people how they do
Just
it.
saying, just bring them. Just, well, oh, hey, do you want to go to the conference?
Oh, bring them. Yeah.
Yeah.
Such a good question though. And I think it depends a lot on like where you are in the power chain of your organization too, for sure.
I think Margaret Ann's question kind of puts me a little bit in the space of something that I think about when we're talking about substance use. Like you've talked about so many different things like the breastfeeding protocol and different moments where it was you noted in your talk that this was a shift from previous protocol, right? Like and this ever evolving, like, and thinking even about language, which you started off with talking about language and what kind of terms do we use. And I'd love to hear you talk a little bit about how you personally help to manage that change process and just continue to stick with that. And because it's just such a huge piece of this puzzle, I feel like, as we're learning better and doing better, hopefully all together.
Yeah. I mean, I think like things like breastfeeding, like I had a patient, all of these patients that we represented are amalgamations of real patients that I've had. And I had a patient just the other day who had been on methadone for forever. And not forever, but for a long time. It was really stable. And, we talked a ton pre-delivery about what she might expect. And what I realized I didn't do is like, I kind of was like, these are the things that are right. And I didn't so much warn her about the fact that she may interact with people who do not hold those same beliefs or not using the evidence base. And so shortly after delivery, she had run into a couple of hiccups that were really confronting those things. And I had to be like, I never want to be in a position where I am sowing a seed of distrust or discontent, because that's not helping, right? So like if I say, well, the NICU doesn't want you to use your breast milk, for instance, and that's wrong, but like that's not helping, right? And so sort of being like, having that space to say like, this is what we know, this is what some other people may want to do because this is their, these are the reasons why they may have for that. And like, we're going to continue to work to do our best, but know that like our best is not always perfect, and to try to be a little bit more thoughtful about that. And I think in reality, doing that sets people up for success, right? Because like if I set up this like dichotomy between you and this other provider, or you and your people who are taking care of you, that's not serving anyone. And then I think it's not the patient's job to be the advocate. I mean, we want to arm them with some of this stuff so that when someone tells them something that they know isn't evidence-based, they know to question it. They know to be like, I don't know if that's right. Can you talk to me more about that? But like, I don't think it's on them to be their own advocate in that way. It's like my job to hustle and go find the person and say like, hey, actually, this is the paper that says this. What can we do to get closer to this reality? And I think it's helpful if you work someplace to know like who's your allies and like how to have those conversations. And it's definitely been a growth for me. Like I tend to be someone who wants to be like, and that's not helpful. And like, how
Yeah.
can we navigate within that space to come closer to reality?
Well, I just want to say thank you again, Dr. Greenberg. There's a comment there in the chat, and thanks all for taking time for this today. I want to just end on lifting up, the moment of possibility that pregnancy really presents to folks who are struggling with substances. Remember that. Keep your heart in that. This is a hopeful time, for most folks, and really thinking about, how can we support individuals to be the best parents and caregivers they can be through these different hardships. And yeah, I appreciate y'all and all the incredible work that you do to improve the lives of kids and families in the state of Montana and beyond. Take good care, everybody, and please join us at the conference if you can. We look forward to convening all again, and thank you again, Dr. Greenberg.